Before we begin the webinar, I would like to take a moment to orient you to the webinar platform. If you would like to ask a question to our presenters, or if you have a technical concern, please type your question or concern in the question box on the Zoom screen. You can also use the chat function if need be. Our team will be tracking the questions that arise, and during interludes in the presentation, we will select questions for presenters to answer. We will also have a formal Q&A at the end of the presentation where you will have an additional opportunity to present questions. As I mentioned, this webinar is being recorded and will be posted to our website soon after. With that, I'd like to get started by introducing today's panel. Again, I'm Jeff Micklos, and I am the Executive Director of Healthcare Transformation Task Force based in Washington, D.C. I am joined by two members today of the task force, Colin LeClair, the Chief Development Officer at Concerto Health, based in Irvine, California. Concerto Health is a leading provider of specialized primary care and supporting clinical services for vulnerable, frail, and elderly patients that operates exclusively in value-based care arrangements. Colin is an accountable care organization strategy expert and has held executive positions at the nation's leading medical groups and health plans. It's great to have you here today with us, Colin.
Thanks, Jeff. Glad to be here.
I'm also pleased to present Dr. Stuart Levine, the Chief Medical and Innovation Officer at Agilon Health. Agilon Health is based in Long Beach, California, and partners with physician organizations to define a new standard of quality, efficiency, and patient experience through the transition to value-based care. In addition to his work at Agilon Health, Stuart serves as the Chief Physician Advisor to Google Brain Health Research, as well as an Assistant Clinical Professor in Internal Medicine and Psychiatry at UCLA and Stanford University School of Medicine. He previously served in a variety of executive roles across a number of healthcare institutions. Thanks for being here today with us, Stuart.
Oh, it's my pleasure. Thank you, Jeff, for letting me participate today and in the task force that you lead.
Thank you, Stuart. Thank you both again. I think it's safe to say we have a very experienced group of presenters today, and we look forward to a lively conversation. So now for a brief overview of what we'll be covering today. Next slide. We are going to first just give you a quick introduction to the Healthcare Transformation Task Force. We're also going to remind you with a quick overview of our social service integration framework that we rolled out in May, and then allow Colin and Stuart to go through their case studies from their respective organizations, a Q&A, and then talk about the next webinar in our series of webinars. So for a brief interview of the introduction to the Healthcare Transformation Task Force, we're an industry consortium made up of patients, purchasers, providers, and payers. We are focused on seeking an accelerating pace to value-based care arrangement. Our payer and provider members commit to having 75% of their businesses operate under value-based payment arrangements by 2020. Here's a picture of our current membership and a list of our guiding principles, which really outline a financially and operationally viable and sustainable approach, focusing on serving, in particular, underserved populations, the high-need, high-cost population. Our work is currently, our major part of our work is currently focused around three work groups. One focused on improving the accountable care organization model. A second, I'm looking for improving the bundled payment frameworks. And where this work resides, new model development focused on improving care to high-cost patients. And now we'll give you a quick overview of the social services integration framework. On this slide, which we presented back in May, that there are a few common chronic conditions that drive much of healthcare spending. As we well know, these conditions can be controlled under the right circumstances. Getting patients medical care is just one aspect. We must address the social determinants of health in order to have a consistent and long-term impact. Which brings us to our next section. Through the work of our Improving Care to High-Cost Patient work group, we developed a consensus framework around social services integration, and it's focused on 5 key pillars. Identifying the target population, identifying social needs, assessing community resources, developing the social services integration model, and then implementing that structure. Where we're really focusing today's conversation is kind of in more detail into pillars 4 and 5 on how to finance around the social service integration model. As you look toward the financing options for social services integration, you'll often find pilot programs that are funded either through public or private funding. Usually an expanded model based, again, upon those funding sources. One of the challenges, though, as we know, and I'm sure our panelists will discuss this, is really finding sustained funding for these programs over time, whether it's through dedicated state funding or Medicaid waivers, or whether it's health system or payer funding. And it's certainly a challenge in the marketplace, as we all well know. When we look at these types of models and the financing questions, the two key questions emerge. Will the program be carved out and held standalone or integrated into the care delivery model? And does the organization have a plan for long-term financing? And if so, who will be the primary funders? Now I'd like to turn it over to our first presenter, Colin LeClair, who will talk a bit about Concerto Health's model and how social services are integrated and financed through this model. Colin, if you might go ahead and give a brief introduction of yourself and then jump into your presentation. Again, thanks for participating.
Great, thank you, Jeff, and thanks so much everyone for joining today. I thought what I would do is start by providing a little bit of context around who Concerto Health is, who we serve, and some brief history, and then get right into it. First, my background is I've spent about 15 years in the managed care space, focused exclusively on Medicare and Medicaid populations, starting with about 9 years on the health plan side on the East Coast, and then in the last 6 years have moved into the full risk medical group space, focused on leading population health and medical management activities. So have been with Concerto Health for the past 3 years. The executive team and I joined about the same time to take over this legacy business and really expand the patient-centered medical home model that we adopted. So with that, I can start with sort of a brief history of the organization. In 2014 and prior, the company was actually a Medicare Advantage health plan focused on the institutional special needs plan population and chronic special needs plan populations in Medicare Advantage. And so we were far out on the acuity scale, serving the most complex, most fragile populations. And the conclusion that leadership team arrived at before we came in and took over leadership of the organization was that the fee-for-service provider model is not very well aligned with the needs of the patients who are institutionalized, who are non-ambulatory or homebound, because you can't assume that those patients will show up at the front door of the clinic. So they developed a field-based model that was that sort of housed the clinical team out of a brick and mortar clinic, but then sent those folks into the field to the patient's skilled nursing facility or convalescent home or adult living facility to treat them where they were and when they needed to be treated. And so it became a very sort of proactive clinical model. And with our arrival, we decided that being a small regional health plan was not the place to be. We wanted to focus on this clinical model and divested of that health plan, the health plan assets. Today, fast forward a couple of years, we have expanded rapidly both the clinical model, but also that field-based model. So we're closing in on about 50,000 lives under contract with Medicare Advantage and Medicaid health plans. And of those lives, less than 20% of them now are sort of clinic-based patients. The balance we see in the field, or those patients often will go to an independent network provider, someone a physician who's not employed by Concerto. And we support that physician to provide care for their patients when they're in the hospital, when they're in the SNF, when they're at home and non-adherent, when they're institutionalized, and so on. So we are an extension of the independent physician practice for for about 80% of our lives. In terms of our location geographies, we provide this sort of IPA network support looking model across all of southern Michigan. We serve MMP populations in southern Michigan. We also serve dual SNP populations in the greater Seattle area, and we're in the middle of implementations in Chicago, Peoria, Columbus, Cincinnati, Toledo, Ohio, and New Mexico on a statewide basis. So in a period of rapid growth and focused, again, almost exclusively on the dually eligible and Medicaid age-blind, disabled, and long-term supports and services population. So very, very frail, very needy population, underserved population. On the next slide, you'll see sort of the impetus for the model. And again, just a little bit more context, but I'll be brief here. We underlying the thesis that drove this new model was a sort of a two-part problem statement. One, on the health plan side, health plans are being met with a lot of sort of nuanced challenges from a regulatory standpoint and from a clinical management standpoint. They're struggling to proliferate value-based payments. They're struggling with patient engagement because direct care delivery has not been something that most health plans are comfortable with or familiar with. They're struggling with primary care access, not just numbers, not just the number of primary care providers and practices that are available, but also the ability to provide access after hours or in the home, or to follow the patient across settings. They're being overwhelmed by the rising sort of standard around quality, HEDIS stars measurement, keeping up with accurate clinical documentation so that they're appropriately funded, and so on. And these health plan challenges are creating a significant burden that's driving things like the macro trends like the mega mergers. You need to have scale and density to be successful, unless you have a really sophisticated payer partner. And what most health plans that are doing that are not these massive, have massive market share and significant sort of influence in their markets, is that they put a lot of this burden on the primary care physician. And so on the other end of the spectrum, the other problem statement is that primary care physicians generally are underpaid and overworked. That's no secret, no surprise. But there's this impasse between the challenge that the health plan faces and the incapacity of primary care practices to meet that challenge. And so it's that middle, that bridge that we sought to solve for in the model that we've developed. Now on the next slide, I'll talk a little bit more about the model. There was really three parts to the model, three tent poles. The first is our clinical services and supports that we wrap around the primary care physician. We're giving them sort of fractional ownership of an interdisciplinary care team. Most physicians don't need one whole FTE of a pharmacist. They don't need a full-time social worker often. Their practices are too small, or they don't have enough patients that require that sort of support. They don't need a full team of care managers, care coordinators, and nutritionists. But what they do need is 10% of those FTEs or 20% of those FTEs. But that's not available. You can't buy that type of resource on the spot market if you're a physician, and you can't manage 10% of those resources. So what we sought to do is create an interdisciplinary care team comprised of all of those clinical resources and administrative supports, and dedicate them, assign them to a physician practice to allow them to accept value-based payments, to take more longitudinal accountability for their patients' care without having to invest in and own those resources. Around that layer of clinical resources, we provide more traditional sort of medical management support. So everything from performing delegated utilization management and helping to drive patients to the highest performing providers in the network, to helping them with clinical documentation and HEDIS quality care gap management, to provider incentives and coordination across the care continuum, giving these providers the means to communicate with the specialists and facilities that are treating their patients, but they may or may not be aware. And finally, all of this system sits on a proprietary technology platform that allows us to communicate with the physician, to communicate with the patient, to allow them to communicate with one another. It creates a virtual integrated care team and communication platform for all of these stakeholders to participate in. And it also provides us a means to send the primary care physician data in an actionable format that allows them to respond in real time to any change in patient status, like an ED visit, a discharge, change in diagnosis, change in medications. It provides a means to deliver a truly coordinated experience for the patient. So that, in a nutshell, is the model. I could spend a lot more time on that, but I want to move to the focus of today's discussion. So I'll flip to the next slide. At the core of the integrated care team, the care manager is the quarterback. So in our model, because we're serving dual populations and MMP, Medicare, Medicaid demonstration program populations, model of care requirements are a significant part of what we do. And those requirements, those regulatory and compliance requirements are rather draconian, and often they're one size fits all. So what we've had to do is develop a system that allows care managers to meet all of those compliance requirements, which includes performing health risk assessments when patients enroll and on a periodic basis, which we believe is of great clinical value, performing care plan updates, care plan changes, distribution of care plans, engaging patients to perform medication reconciliations on an ongoing basis, medication therapy management, and then doing sort of general follow-up with patients to perform ongoing assessments, whether the patient's an ED frequent flyer, assessing their risk for another ED visit or for readmission post-discharge, and so on. But the challenge, as you can imagine and you all know, is our patients are hard to find. They're difficult to communicate with. Their first concern when they wake up in the morning is not whether their A1C is managed, generally. It's not, the traffic. They're concerned when they wake up with where they're going to sleep the next night. They're concerned with whether or not the power is going to be on, whether or not there's going to be food in the refrigerator. And the reality for us is that if we don't resolve those issues for them, we'll never get to talk to them about their A1C. We'll never get to talk to them about their blood pressure and their meds adherence. So social workers become a critical component of our care management apparatus. What we do is when we perform our initial patient engagement outreach and health risk assessment, we're also doing a social determinants assessment. Social workers become the shepherd of our patients. They're the friendly, warm hug that the patient gets when they become part of join one of our care management programs. Social worker is tasked with performing some very specific and discrete activities, like performing the social determinants assessment, doing periodic reviews of the community-based supports, and facilitating patient re-enrollment in those supports, things like Meals on Wheels, subsidized utilities. We're looking for grant-funded programs that are available to them in the community, but we're also talking to our health plan partners to encourage them to offer value-added benefits like subsidized cell phones so that we always have a means to reach our patients. We're constantly managing the sort of a CRM database, in effect, of all of our patients, all of the programs that they're enrolled in, when those programs are going to expire, and how do we re-enroll them, how do we engage the patient in that process to make sure that they don't have lapses in those services that they need. But on top of all of those social services and supports, social workers are held to clinical outcomes, because we know that if the social worker doesn't engage the patient and they don't provide these services, that it's the clinical outcomes that will suffer, not just the fact that the patient will not receive their Meals on Wheels. The downstream outcome from missing those opportunities is that they're going to go back to the ED because the ED is warm and they're going to be fed. They're going to call the ambulance when they need help. So that social worker engagement is critically important. The services that they're facilitating enrollment in are critically important, but we hold social workers accountable to the same clinical outcomes that we would hold a nurse care manager to in terms of accountability. So that includes number and frequency of PCP visits, number of ED visits, ambulatory sensitive condition admissions, total acute admissions, all-cause readmissions, and meds adherence. So we hold our social workers to a very, very high sort of clinical outcomes bar, not just their completion of administrative tasks or enrollment in social supports. On the next slide, this is very small, so I apologize for that. But what we've done is given you an illustrative view of how we staff. It's really important that that we tailor the resource investment in social work, in terms of social workers, to the patient needs, the population needs, the economics of the eligibility cohort that the patient is in. It is hard to measure ROI for social work, and I'm afraid to say we don't have the perfect solution to measuring ROI. What we can tell you is that social worker patient engagement with social workers is very, very highly correlated with better engagement in care management activities, which is then very, very highly correlated with better outcomes in terms of fewer inpatient admissions and readmissions. But we do also know that there's diminishing returns in terms of where our social workers are doing. So we look at a number of variables when we're staffing our social workers, and I hope that this would be a helpful sort of tool for you to take away for your own organizations. We start by assuming that every patient that comes in before we perform our health risk assessment is of medium acuity, given within their population, within their sort of eligibility cohort. So, and then we have, based on sort of empirical studies and experience, determined that these sort of medium average risk staffing ratios for care management and for social workers are about right. They're holding all other variables equal. And then what we do is, after we've performed the health risk assessment, we have looked at population density, we've looked at provider practice patterns, utilization behaviors, other social complexities that may be at play or prevalent. We'll toggle and tweak those staffing ratios to ensure that we are appropriately adapting our social services model to the patient need and the specific sort of product parameters. So among the data that we're collecting right up front are medical claims, data from our health plan partners, lab values from both lab vendors and from our health plan partners, RX encounters from e-prescribing data or from EHRs, and then our social determinants and health risk assessment data. And we're creating a repository of all that data, and that's being refreshed on a nightly basis. We're getting these data feeds from across the delivery system and refreshing our algorithm dynamically so that we're always reassessing patient risk from a number of different sources. And then we're toggling the staffing ratios that we need. Now, staffing ratios, of course, for a large organization approaching 50,000 lives are not going to change overnight, but we do look at directional indicators to make sure that we are staffed appropriately over the course of the next month, for example, given changes in the inpatient acuity. And then we're also looking for, as a new population comes on, what are the changes in the compliance requirements? Does a state Medicare, Medicaid program allow social workers to act as a care manager? We think there's a lot of value in having social workers perform a lot of the care management responsibilities and practice sort of at the top of their license, but that may not always be allowable. And so some of what we're doing is adapting to model of care requirements, whether they're filed with the DSNP product or required by the state. And we're constantly refining and tailoring the staffing ratios to the patient population need. I think there's a risk of false precision in tweaking staffing ratios too frequently. I think the best practice is start with average and work out from there. The goal being trying to identify where your diminishing returns are, looking for the point at which you stretched your social worker capacity and productivity, and don't think that the next social worker LCSW or MSW is of significant, meaningful additional value, and we've had the benefit of scale and a meaningful sample size to assess that. So I think this is a helpful starting point if you'd like to use it. At the end of the day, for any given population, we're spending between $4 PMPM and $40 PMPM on social worker support. So wide range, evidence of the fact that different populations need a different level of care. And so the $4 PMPM is more representative of an ambulatory MAPD looking population. And $40 is more representative of a long-term supports and services population who needs intensive social worker support and social services support. On the next slide, I wanted to briefly describe how it is we manage and drive productivity. And I'll be brief with this. I could spend a day and a half on this, and I'd love to do a follow-up with anybody who's interested. But the technology that we've developed was designed around the compliance requirements because there are so many in the DSNP model of care, models of care, and MMP models of care. And so what we were attempting to do is to get through the administrative requirements as efficiently and effectively and timely as possible to make sure that our health plan partners score well during their HSAG and ODAG audits by CMS in the state. And then the goal is to, once we've completed those compliance requirements, let's also capitalize on that precious opportunity where we're interacting with the patient either face-to-face or telephonically to address all other open care needs. So the system shows the care manager or the social worker exactly what's due today, what's most urgent, what's the most critical need from both a clinical and compliance standpoint. It walks them through how to address that with the patient, how to document it with the patient. And then it also shows them for that patient, while you have them on the phone, to talk to them about their L1, their initial health risk assessment. Let's also discuss the fact that they were prescribed 5 medications. They only filled 3 of them according to claims data. And according to the last discussion that we had with this patient, they were only taking 1 of them. Let's have that med rec discussion right now while we have them on the phone. And the data is showing the care manager and the social worker that data in real time. It's also notifying them of any recent ED visits, recent hospitalizations and discharges, any changes in diagnosis, and those sorts of things. So we're giving our team a comprehensive view of the patient and corresponding activities. What is actionable? What can I do today? What assessment can I perform? Who can I connect this patient with? Can I refer them to disease management? Can I refer them to a specialist? Can I refer them to a telemedicine professional, a psych professional? And so the goal is to make it as efficient as possible to complete all of the compliance requirements and make sure that we're also addressing all the patient's urgent clinical needs in the right order of priority, so they don't have to manage spreadsheet after spreadsheet after spreadsheet to keep the patient enrolled in social services support and so on. So very, I think, cleverly designed tool. I think you could probably create a very lean version of this using an off-the-shelf CRM system with some customization. We've had to go and develop our own proprietary solution because we're managing volume and variation across sort of scaled operations. So would be happy to take this offline and show you more about this, but this is what allows us to manage social work activities effectively and efficiently and get the most out of that team. On the next slide, wanted to share with you some sort of performance results. Again, really hard to show and demonstrate causal relationship between social worker activity and outcomes, but what we do know is correlation is very, very strong. So what we have found for our dual populations is pretty consistent precipitous decline in admits per K. And that's not attributable to sort of denial rates and activities. There is some of that where we're redirecting patients when they hit the ED and getting them to move to OBS or move to a SNF or maybe are released and we're coordinating a follow-up visit the next day. But most of this is proactive preventive care. We're preventing index admissions. And we know that empirically. And we know that the likelihood of preventing index admissions, the likelihood of preventing readmissions goes up significantly where there is social worker engagement, where social workers are facilitating Meals on Wheels or facilitating enrollment or redetermination of Medicaid eligibility so they have access to additional benefits. And so we do know that the work that our social workers are doing is leading to better clinical outcomes. Really difficult to measure causal relationship, and I think that's why ROI is so hard to measure, and reinvestment is so hard to justify often and historically. But our experience indicates that it's absolutely a worthwhile investment, and our admits per K and our readmissions are telling the story for us that it is working. On the next slide, I thought I would spend a moment describing what we see as a couple of the most common means of funding this model. We're admittedly a unique animal. We are a globally capitated medical group. We accept total risk for total cost of care and total quality, both Part A and Part B, professional and institutional costs across our populations. I think 95 or 96% of the lives under management are under globally capitated arrangements. But that's not for everyone. What we have seen work, because we work very closely with independent physicians as well in the fee-for-service environment, is providing them that fractional sort of ownership, if you will, of a social worker, dedicating a social worker to the practice, and allowing them to access that social worker as needed to support their patient populations, where they find a need for that 3% or 6% or 9% of their patient panel that does need social worker support. We provide them access to that resource. The challenge that most of the physicians that we work with have seen historically is that there are very, very few compensable services that social workers can provide, and so their practice can't afford to employ and then bill for their own social worker. So giving them fractional ownership is really the only alternative for them. The reimbursement rate for those social workers tends to be quite low, even if they do have a sizable Medicaid or a vulnerable population, and so it's still hard to justify a full FTE. What we're effectively doing for those individual physicians is providing them something that looks like the ACO or POD model, where we're sort of giving them a pooled resource. We're dedicating a social worker to 6 practices, and across those 6 practices, 1 FTE has a full-time job, and the practice has all of the social worker time that they need to care for their patients and to monitor their patients. The challenge we have run into, and I've seen come up in the ACO environment, is that physicians, traditional primary care practices are far more comfortable with the face-to-face care delivery model. So the idea of having a telephonic resource or a part-time resource, a Monday, Friday type of arrangement, is difficult to adapt to and difficult to schedule around. So what we've done is taken that administrative burden off of their hands by proactively scheduling social worker visits in the field, either at patients' homes or in the office where we can. We're doing the scheduling of that the physician office would otherwise have to do. We're asking them when patients are going to be in their office for the next visit, or we're scheduling that visit for that patient and on behalf of that office, and making sure that our social worker is available when that patient comes in, or sending the social worker to their home. So we're taking over the administrative scheduling and logistics management for them to make it easier for them. The challenge remains, though, for these ACO or pod-like models where they're sharing a resource is beyond the scheduling and logistics is reimbursement still remains relatively inadequate if they're billing fee-for-service, but also across a small sample, it's hard to demonstrate that there's ROI there. You really need scale and volume of interactions to demonstrate that social worker engagement leads to better patient outcomes. So we continue to believe that the best model for funding social worker activity is through capitation, and we have experienced managing that through 3 different models. The first is broad scope PCP capitation. So when we first engage a health plan partner, rarely do we start day one with under global risk, 100% upside downside risk. That almost never happens. What we do typically is work toward a sort of minimum volume of patients and a minimum sort of duration or period of time where that gives us enough room to watch utilization, to identify disease prevalence, practice patterns, understand where the gaps in care are, to give us some runway to move and transition, phase into global risk over time. But by starting with broad scope PCP capitation, so think sort of $45 PMPM in some markets up to $65 PMPM. What we can do is use those resources to both incentivize primary care physicians better than they would otherwise be incentivized to take on some of the administrative burden associated with value-based payments. But it also allows us to invest in care management resources and social worker resources to supplement multiple practices. That's a great way to start. It's relatively low risk because you're only at risk for the PCP dollar amount. But some health plans will require that you have some skin in the game because of the larger PCP capitation. In particular, plans are often interested in having you take some risk for institutional care because they don't want you to just sort of take the PCP cap, stop seeing the patient, and let them go to the ED. So there's typically sort of some ED visits and quality incentives that you'd have to sort of take on to enter into this arrangement. The second is Part B. The second model that we have experience with is Part B capitation. So really sort of professional services capitation, larger upfront capitated dollar amount allows you to use more discretion and invest more broadly in those services that directly and immediately impact healthcare outcomes. This gives you much more flexibility to experiment with social worker support and integration into care management. Generally, we accept delegated care management in this arrangement. So we are actively integrating social work into our care management model when we enter a partnership under this type of arrangement. And finally, global capitation, where we're taking 100% upside and downside risk for cost and quality. And here we have 100% discretion as to where we invest in clinical resources. And under this model, we're taking delegated utilization management, delegated care management, and we are fully integrating social work, social supports and services into all activities, including the interdisciplinary care team, communication across interdisciplinary care team stakeholders, specialists, facilities, the primary care physician in the clinic, our own field-based team in the field. They're an integral and central role in this interdisciplinary care team, and we have the discretion to invest in them in a way that we never could if we were dependent upon billing for them in a fee-for-service model. So just a few examples of how we've seen the integration of social services successfully funded and integrated into practice, and hopefully that's helpful. Would be happy to go into greater detail and follow up to this conversation, but I hope that was helpful and interesting.
Thanks, Colin. That was great. Great information, particularly going deeply into the last slide here. Very helpful information to tie it all together, and certainly a challenging environment, and it's great to see the different ways that you all pursue it there at Concerto. And with that, I'll turn it over to Dr. Stuart Levine and hear a bit about the work that they're doing in Agilon Health and how they are financing social service integration. Stuart?
Well, thank you, Jeff, and thank you, Colin, for a great presentation. It's interesting since I know of your company and know you. We're doing very many of the same things and have a similar approach towards management of patients, especially high-risk patients. I'll talk a little bit about what we're doing at Agilon and also other models of social work that I've seen be successful in other organizations that I've been working in. We have similar results that you've had, and at some follow-up, I can present those. But something about Agilon. Agilon is a company that's been in existence for about a year. I was one of the founders. It is primarily a health delivery system. We are not a consulting company. We're not an MSO. We're not really a technology company. Agilon is a company that partners with delivery systems in geographies all over the country. That includes in Los Angeles, in the Central Valley, in Hawaii, in Central Ohio, and now other parts of Ohio, and soon to be Texas, Illinois, New York, and Northern California. We are premised on finding delivery systems that want to move into global capitation with a focus on government program patients. Our entire model is in investing in the entire healthcare dollar to improve care and improve outcomes for patients. We are very convinced and have had a long track record of ensuring that achieving high quality reduces total cost of care, and have done it now in a number of settings, including settings that are not so easy, and with a variety of patient populations. The patient populations that are included in here are Medicaid or Medi-Cal, the TANF patients, SPDs, dual eligibles, and Medicare and Medicare Advantage. We are working with other populations that are not in global capitation, but frankly feel that the premise for truly investing in the delivery system that I'm going to describe is based on the global capitated dollar. And in working with other populations, you can only do that and do that successfully if you have a highly dense population, minimum of 20,000 commercial equivalent, 5,000 seniors in a 5 to 10 mile geography, and then manage everybody else off the margin. The next slide talks about our clinical model, and it is very patient, physician, and family focused. The goal of our delivery system is to ensure that every patient and their family get ultimately excellent care, and that we bring the joy back to the practice of medicine for physicians. The way we've approached our partnership model has either been we've bought some IPAs or medical groups, or much more often we partner with them. We set up a joint venture risk-bearing entity with that medical group or IPA in the region. We fund the building and development of the infrastructure for that and take the downside risk, and essentially operate a delivery system with the physicians. This is a primary care-based model that's most important. In what we'll talk about a little bit later in our model is that we truly reward and incent the excellent doctors, and we support and provide the safety net to the average physician whose practice does not allow them the time or the energy to really concentrate on the highest risk patients. And our model is based on managing the most challenging and the most chronically ill, both medically as well as psychosocially, to achieve this result. As part of that, therefore, building social work into this model has been crucially important, and care management is the crazy glue that holds a high-risk delivery system together. I have been lucky enough to work in other situations where social work has been very successful. I'm on the board of Partners in Care in June Simmons' organization, where she provides social work as a wraparound to other delivery systems, and she's achieved excellent success in doing that, especially with systems that are not fully capitated and do not have heavy social work in their model. I've been lucky enough to be the medical director and CMO at Scan Health Plan, where it was a social HMO, and social work was the premise for managing home and community-based services for the frail and for those nursing home certifiable patients. In addition, I was one of the co-founders with Jürgen Unser of Impact, where we use social work to embed behavioral health and practices throughout the model. But at least in the Agilon model, we've premised social work teaming with nursing, especially nurse practitioners and nurse care managers, to achieve that success. This slide demonstrates the various places that we focus on the management of the highest risk patients. In seniors, the 20% highest risk patients, dual eligibles, the 25+% high risk patients, and Medicaid and commercial and patients, 5 to 6% highest risk patients, SPDs in about the 18% highest risk patients. And our model is not a primary care medical home as much as a patient-defined medical home, meeting patients where they're at, providing them the care that they need in an integrated fashion with social work front and center as part of that team members, and to really ensure that that patient gets the care that they need. We like to describe our model as 6 pillars of care. A reinvented primary care model where primary care doctors are truly incented to be able to provide the care that the patient needs, but for those highest risk patients, manage them in our high risk model and incent the PCP to be a participant with our high risk program, but to allow the highest risk patients to be managed within the high risk programs rather than in their practice, because the intensity is oftentimes more than can be managed. For the other patients that they have, we do try to embed care managers in practices that have high enough density of patients in that practice, or bring those patients into our high-risk delivery model because it's not practical. We did try what Colin talked about, which was having it be part-time in a practice, and did not find that was terribly successful. And actually, there's a number of models that have demonstrated that works sometimes, but not often. So we've gone to alternatives of building the safety net around them. In addition, we've built models. Important part of this model is around specialty care and ensuring that specialists are paid to think and consult and collaborate more than doing, and really build that as part of the primary care base. The other 4 pillars of care that are critical is the hospitalist, SNFist, advanced facility care portion of this. It's very focused on the patients that do end up in the hospital, but the hospitalization is a failure. And we manage that very intensively, and we do anything as an alternative to hospitalization because neither the patient or the health system want to nor can afford to do that. A second pillar of the high-risk model is the complex care clinic, or the comprehensive care clinic, where patients are managed by teams, social workers being a primary component of that team, with physician leadership, nurse practitioners, and nurse care managers, as well as health coaches, health advocates, and managing that highest risk patient. And a home visit program where we go to the patient. That home visit program can include wherever the patient defines their medical home. It can be in a shelter, in a long-term care facility, in a dialysis center, or at their home. And that's generally 5% or more of seniors, 5 to 7% of dual eligibles, and a couple of percent of the Medicaid patient. That home visit program can include palliative care. It can include homebound. It can also include that patient who just does not want to come to care as you normally know it. And it really is heavily based on the GRACE protocols by Steve Council and the Regan Strife at Indiana University protocols, as well as a heavy home and community-based model and social work model that looks at the social determinants of healthcare that drives this. The next slide. Patient profiles in agilon Health. We have about 70,000 globally capitated Medicare patients, 550,000 capitated Medicaid patients, 10,000 dual eligible patients, about 10,000 commercial patients. The conditions that we primarily are looking at that drive lots of the utilization includes asthma, COPD, CHF, cancer, chemical dependency, chronic pain, CKD, SRD, major depression, high-risk pregnancy, and stroke. But those are the typical issues that you have, and a tremendous concentration on palliative care. But each of those conditions clearly also include the social determinants of healthcare that drive lots of this, which is where social work becomes front and center. In our home visit program, it's the nurse practitioner social work team that does 90% of the work and really does deal with the patients that are of that highest risk, where most systems just sort of say, we can't do anything about it, but we really realize that we truly have the responsibility for that patient along the continuum. As part of our high-risk clinics and care management programs, Generally, there's about one social worker for every 4 nurse care managers as part of the team, where they really do work as a team, and they don't individually manage the patients, but are a participant with their nurse care manager partner in managing those patients. About 10 to 30% of patients are eligible not for care management services or really enrolled in care management services, since as a medical group, we don't worry about eligibility. We just worry about outcomes, patient attention, and participation of patients in our programs. And at least 25 to 30% of all patients receive social services as part of our high-risk programs in care management. In each of the populations that described above, the 70,000 Medicare Advantage patients, the 550,000 Medicaid patients, the 10,000 dual eligibles and commercial, there's different types of social work needs in each of those categories of patients. And so how we design the social work and care management programs are significantly different. The other part to that is that care management and social work interventions cannot exist on their own. And lots of people will build care management programs and manage patients around the edges, but we really believe that it has to be part of a care plan that has the care delivery front and center. So even those patients who are simply in care management, telephonic and in-person care management always have as a component of actual care delivery, whether that patient's enrolled in a group visit program, not just education, but group visit care programs, or other kinds of higher intensity interventions because of the complexity of what they need, whether that's management of medications, medication reconciliation, adherence with treatment programs, or management of the family stressors that drive lots of the needs of patients. So that's really critical. Next slide. This is a description of the migration to a globally capitated delivery system where this is the operating system by which we do it. In the top left-hand corner, it's the acute and post-acute care, and post-acute care being much more comprehensive because hopefully it's the pre-acute care where they never get into care delivery, not just post-acute, where people use that as, well, this is the new horizon of healthcare. Frankly, if they've gotten into acute and thus post-acute care, we've actually missed the boat. This includes the hospitalist team, the SNFist team, care transitions, extensivist and high-risk clinics, home care, care management, and utilization. This is where social services is embedded and front and center as part of each of these programs, and there's a social worker as part of every single component of this high-risk program. This is where lots of the focus is. Similar to Colin, most of our advances in improvement in care delivery and efficiency, as well as, most importantly, quality, has not been based on utilization management. In hospitals, our goal is to get rid of utilization management, even as a piece of it, and it's all premised and based on care transitions and any handoff of care. So care transitions is not just defined as care transitions from a hospital to the home, but also care transitions going any handoff between care between primary care and specialists and primary care and various high-risk programs. The other important thing that we found is that none of these programs can sit by themselves. It's far more important to have the fabric of all of the programs together to make this successful, because the handoff of the patient between varying levels of intensity is critical. And we'll go into the next slide in a second. We'll talk about how we have to risk stratify patients and risk stratify doctors to ensure that patients get the care that they need. The other components of the operating system also includes a really effective and efficient management structure of managing the administrative services, managing all of the problems that the day-to-day PCP has, whether they're employed, like in our Columbus model, or other areas, or whether they're IPA docs, where we're there as a consolidator of the delivery system, contracting, and then ensuring there's best care. This is a risk stratification model on this slide that talks about how to match the acuity of the patient with the intensity of care. And there really is a diligence around this. Generally, to build this high-risk program costs about $60 per member per month across the continuum For seniors, about $15 for commercial, $11 to $12 for Medicaid. SNP is about $45, and dual eligible is $65 to $70. And the overall spend rate for each of these programs are in that right-hand column. Building those teams and making sure the patient's in the right level, in the right place is critical. And one goes on to the Healthcare Transformation Task Force website. You'll still see 3 papers that we wrote on risk stratification and matching the acuity of the patient with the intensity of the program. This is also important to have all of them because patients go up and down this pyramid, and therefore their care and the intensity of care has to go up and down the pyramid, and the handoff between them becomes essential. This is important because when you're building in a employed model, one needs to make sure that that employed model either has the capability in the physician and the care delivery to handle most of this stuff outside of the home visit program, or that you build these programs to wrap around that doctor who's not wholly invested or does not have the capability, the wherewithal to take care of these high-risk patients. That's much of our model, as I know that it is with Colin and other high-functioning delivery systems. I know we only have 3 minutes left, so maybe next slide, please. This is a description of the clinical models. The thing that one needs to take away from this is that people build programs, and they end up managing so many programs that it becomes hard to impossible to actually make successful. And so people will build heart failure programs and COPD programs and asthma programs and osteoporosis programs and fall prevention programs, and it is virtually impossible to do. So in our model, what we've suggested is that we build essentially 6 pillars of care and manage the individual patient and their medical and psychosocial social determinant needs within those settings. So a primary care model, a specialty model, a care management model, high-risk clinic model, home care, and hospitalist, and that we're agnostic to the presenting illness of disease and social determinant problems, and we manage it within that model, and that makes the team care much easier to manage with a higher degree of success, return on investment, and cost effectiveness. This also allows it to start in a small geography with small patient populations without the necessity of having 6 or 7 or 800,000 lives that we have, where we have the fortune of having fairly high density in confined geographies. As you see in a home care model, you'd have palliative care and hospice, ESRD, medical home, long-term care, intermediate care, short-term stabilization. In high-risk clinics, it could include long-term geriatric patients, short-term things around chronic pain, cardiovascular, orthopedics, oncology, et cetera, group visits, post-discharge clinic, freestanding infusion and wound centers, and wellness and prevention programs. And same thing with care management. It includes care transitions, complex care, disease management, all by the same teams, and then care management and social work is built into each of these pieces. And hopefully this illustrates how this works successfully. In the last 1 minute that's left, how about we go to the next slide, please? One important thing I just want to mention, and then we'll go into summation, is that it's also really important to risk stratify physicians, and that not all physicians are created equal, and that by building this wraparound high-risk program and supplementing and supporting physicians to practice at the top of the license, and the team care that's with them or surrounding them practicing at the top of the license, helps make this both more cost-effective, but way more importantly, can achieve higher quality success. And so looking at your physician population, because an excellent physician and an okay physician are going to manage that same patient differently with different outcomes, this becomes a defining factor that people don't talk about, which is adapting your delivery system both to the physician population, the geography of the community, et cetera, to make a lot of success. And last slide. Return on investment. Care management return on investments from our program has ranged from about 2.5 to 4.1, transitions of care around 1.5 to 1. When embedded in integrated delivery systems, that actually scales to about 3 to 1. Hospitalist SNFs programs, 5 to 1. home care, not home health, and high-risk clinic programs about 7 to 15 to 1, and embedding these programs in integrated delivery systems, achieving the highest ROI. A basic take-home for this is when this is not a globally capitated environment, the only way to deal with ACOs and the other stuff is to manage it off the margin when you have this built, because you're not going to achieve anything close to the success that's anticipated unless your starting point is far different than what we have in Southern California, where there's such a mature and sophisticated market. But the most important thing is that this actually can be done, and if we all pull together to make this successful, we can really change healthcare.
Thanks, Stuart. A lot of good information, and we appreciate both speakers today. A lot of information. We really don't have questions from the field, and we are running here at the top of the hour, so I'll make a decision here that we will end for the day. Appreciate, again, our presenters joining us. They're both available for any follow-up. We'd be happy to facilitate that for you. Just as we do wrap up, I'll just share a little bit more about an exciting project the task force is releasing this month called the Transformation to Value Project. It's a work that our organization has undertaken to understand the challenges associated with actually moving an organization from volume to value, really focusing on cultural and operational changes beyond just models. So that will also actually be the subject matter for our next webinar in October. We do not yet have a date on that, but we will make you aware of it just as quickly as we can. Again, for today, thanks to our presenters, but most of all, thank you to the participants on today's call. We will post the materials from this presentation along with a recording on our website within the next day. You will be able to access them by going to www.hcttf.org. You will also receive a short survey via email in the next 24 hours that seeks your feedback on today's webinar. We hope that you will join us on future webinars and give us your feedback so we can make sure those best serve your needs. And thank you, and have a great afternoon.